talk about some things today. A little bit of blood flow, a little bit of blood clotting. You probably had in previous physiology courses of what the blood clotting cascade. I'm not going to ask you to memorize that another time, like you've memorized the Krebs cycle 50 times in your life, clotting cascade 50 times in your life. So we're just kind of gloss over some specifics that are related to clinical practice. So here we go. First of all, you need to understand what arteries are all about. You take arteries like the aorta, the iliacs, carotids, large arteries like that. They're called elastic arteries because the wall of the artery is primarily made up of elastic fibers. It has to absorb the shock of systole 60 times a minute. Unfortunately, they don't have a great deal of muscle around these arteries, and which is a contributing factor to the fact that aneurysms can develop in these arteries frequently. Once you get out into the distributing arteries, they're known as muscular arteries. And this is sort of characteristic of a muscular artery here. You'll see on the top left there, the lumen, and then inside the lumen, the wall of the artery itself is covered with endothelium. Endothelium is one cell layer thick, and it's a squamous cell layer. It's flat, one cell layer thick. Behind the endothelium, there's a basement membrane and an internal elastic lamina that you see there. Deep to that is the tunica media, which contains smooth muscle fibers. So in the picture on the right, the nuclei of the smooth muscle nuclei are seen here. So depending on how big the artery is, that'll tell you how thick that muscle layer is going to have to be. And then outside of that is the tunica adventitia, which is the layer that just melds with the surrounding subcutaneous or muscular, whatever the environment is. It becomes continuous with the surrounding environment. Okay? Because of the thickness of the muscle there, that gives that artery the ability to contract or relax, influence blood pressure, influence perfusion throughout the body. If you're doing something and you need to shunt blood from one place to the next, the muscular arteries are the guys to do it. If you're running, you need to shunt blood to the muscles, to the skeletal muscles, because they need more oxygen. The arteries going to the gut will contract. The arteries out into skeletal muscle will dilate. If you look in the smaller vessels here, the thickness of the muscle layer gets much smaller, but it's still there on the arterial side. And this represents an artery on the top and a venule on the bottom here. You'll notice the venule has essentially no muscle layer. It's only the large veins that will have any type of muscle. Most veins in the body do not have the ability to contract, whereas the small arterioles even have a layer of muscle, have a tunica media, and are able to elicit a contraction. Versus lymphatic channels, which are nothing more than channels lined by an endothelium. They have no wall structure really at all. They do have, like the veins in the limbs, especially, they do have valves, and this wispy stuff right here represents a lymphatic valve. But the interesting thing about a lymph is it has no ability to contract whatsoever anywhere. It's dependent upon its location in the tissues and the actual movement of the tissues around it that drives, that kind of squeezes lymph flow towards the thoracic duct. You know, so if you have something where there's not a great deal of movement, movement facilitates lymphatic flow. Let me just put it that way. Movement facilitates lymphatic flow. That's why you have people, some people with lymphedema, you want them to be moving. You want to put compression type stockings on them because it's the compression that moves lymph. There's no other force behind it other than the hydrostatic force that will do that.
So you said large veins do have some kind of muscular?
Yeah, they have a muscular layer. But again, once you pass through the capillaries, the pressure on the venous side is so low, you know, most of perfusion is going to be determined more on the arterial side in terms of its blood pressure and vessel diameter. Now, capillaries are wonderful little boogers. They have no muscular coat whatsoever and are 1 cell thick. Here's a capillary in a lung. These are the alveolar spaces out in here. The lung tissue itself, there are 2 types of cells in the lung tissue. One is called a type 1 cell, and it's what forms the majority of the alveoli. So this is made up of the 2 membranes of a type 1 lung cell. Type 2, these are the cells that are found in the junctions of the alveoli. The type 2 cells are the ones that produce the mucus, the surfactant for the lungs. Anyway, I digress. Going back to the capillaries, these things are small enough that most blood cells have to stack up, as you see here, to get through it. So gas exchange in the lung has to go through the membrane of the endothelial cell and in the membranes of the type 1 alveolar cells. This is a transmission electron microscopic image of a capillary. Red blood cells on TEM slides always appear as this homogeneous dark structure. This would be the plasma proteins and other stuff circulating in the blood. Well, here's the endothelial cell nucleus right here, this dark structure, and then the cell itself wraps all around. So you understand that in order to get gas exchange, it has to go through the inside membrane, then diffuse across the cytoplasm, and through the external membrane, and then you've got to do the same thing to the type 1 alveolar cell. Okay? In most places of the body, the endothelial cells are connected to each other by these things called tight junctions. And that's what you see here. These darkened structures here are tight junctions. Stuff cannot get through there. If you're going to get something through the endothelial cell, it has to go through the cell. It can't go between the cells. Versus these types of capillaries, these are called fenestrated. You find these in several different places of the body. The most notable one, or the most interesting one, are the fenestrated capillaries of the kidney. The kidney's in there somewhere, kidney, that allow for passage of certain things, but the holes aren't big enough to allow for passage of anything large like albumin molecules or certainly blood cells. And so here's a capillary right here. You see these little holes or gaps in the membrane itself. And they would be actual holes, round holes in the membrane to allow for exchange of water, electrolytes, very small molecules. Well, if you're talking about the kidney, what would be too big to go through that hole would be, as I said, albumin, immunoglobulins, large proteins like that. Okay. And then there are some parts of the body where the holes are so large, they do allow for blood cells to go through. And these are called sinusoids. And probably the most prominent sinusoid is the spleen. Blood pours into the spleen, into the vessels of the spleen, and then it drains. The RBCs leave the capillary. The holes are so big, they're over 7 microns in diameter, they just leave the capillary. And, are sitting or floating around out in the spleen itself, where other types of cells recognize them as old, worn out, and they'll get rid of them. And then at the other end of the spleen, they kind of come together back through those big sinusoids and re-enter the circulation as a splenic vein. But they're huge sinusoids. I will never forget in my graduate school days, all the histology and electron microscopy of the spleen, I could just never get a handle on the splenic circulation and how complex it is. I kind of simplified it there, but essentially that's what it is. Blood dumps into the spleen, you get rid of all RBCs, it re-enters the sinusoids and out the splenic vein. So, lymph nodes are also like that. Lymph nodes right here. The bone marrow is certainly like that. The venous blood just pours into the bone marrow, into these great big open spaces between the bony spicules. It's truly impressive. All right. Now let's talk about clotting. So when you say the word clot, a clot refers to something that happens out here. I got a blood clot. There's a blood clot. You see the clot? I cut myself. It clotted. That's a blood clot. Hemostasis inside a vessel is not technically a blood clot. It's a thrombus. It's called a coagulum. It's not technically a clot. But we are so ingrained to calling it a clot, I'll probably mess up 100 times in this lecture and call something that goes on intravascularly a clot rather than a thrombus. But understand there is a difference between the two. If you're looking at external to the vascular system, a clot can be defined as one of these 3 types of appearances. One is petechiae. These are small purplish to reddish to blackish small spots. It's very local extravasation and clotting. There are a lot of diseases that produce petechiae. Next up is purpura, which is, I'll show you an example later on of a case of purpura. It's a more widespread or larger clot outside the vasculature. And finally, ecchymosis would be what you would think about as bruising, which can be large. All right. Postmortem intravascular coagulum. The only reason I put this on here is how do you distinguish in a dead person, did that clot cause their death, or did that clot form after their death? So we'll talk about that for a few minutes. You remember in the cadavers here, you people have been pulling these clots out of the pulmonary circulation, the heart. Well, was that actually the cause of the death, or did it just form later on? Right. Hemostasis, let's talk about blood clotting to start with, and the formation of the coagulum. The thing about it is you have this very complex interrelationship between the endothelium, the platelets themselves, and all sorts of circulating enzyme or inactive enzymes and even anticoagulation factors, because as soon as you form a clot, you want to start getting rid of it. Or as soon as you form a thrombus, you want to start getting rid of it. Or you want to limit the extent of the thrombus, otherwise you're going to be nothing but a big thrombus, which is not a good thing. All right, so at the site of a hemorrhage, or damage to a blood vessel, any damage to a blood vessel, these are the things that happen. Vasoconstriction, which I think we talked about early on, was one of the first things that happened. And then you get the formation of, I guess you'd call it a platelet plug, clogs the hole, and then fibrinolysis, which is the removal of the clot, or digestion of the clot. All right, vasoconstriction. Again, we talked about in what's going to constrict will be the arteries and the arterioles, and to a smaller extent, large veins. What causes them to constrict will be neural factors and hormonal factors related to things that are released at the site, like substance P, bradykinin, those type of things that we talked about before that have a local reaction or vessel contraction. Okay? Understand that if you decrease the diameter here, and the blood flow is in this direction, you're going to slow down blood flow here, but in the site itself, blood flow speed will increase because you're decreasing the diameter of the vessel. But it's the slowdown up here, the stacking up, that you're interested in. All right, platelets. Platelets, we mentioned platelets before. I showed you a slide showing you the little platelets. They're actually little pieces, they're little chunks of a cell called a megakaryocyte. The megakaryocyte is this huge cell that's probably about 10, 15 times bigger than an RBC. They're located only in the bone marrow. And they bud off little pieces of their plasma membrane containing whatever was in the cytoplasm. Usually a bunch of little vasoactive substances, and substances related to clotting. Okay? So you have normally around 400,000 platelets per milliliter of blood. 400,000 platelets per milliliter of blood. When you stop and think about it, that's a lot of platelets circulating. Primary hemostasis. What happens here is we have a rip in the endothelial cells. And let me define a couple of things here. ECM stands for extracellular matrix. Mostly what we're talking about is collagen in the basement membrane. EC on these slides stands for endothelial cells. All right, so we have recognition of the extracellular matrix by the platelets. They have receptors that are sticky to the extracellular matrix, and they will start binding to it. And I'll show you in just a second how they do that. But you can see that they start binding to and start to plug the hole. Now, there are a couple of things that happen. One is they change the shape from their biconcave disc to more flattened structures. And the second thing is you get the release of adenosine diphosphate and thromboxane A2. Now, the reason I point out these two substances here is because there are a lot of diseases or instances where you need to have somebody on an anticoagulant. You need to stop the ability for the blood to clot. If you get a heart valve, that's a mechanical valve, if you get a stent put in your heart, if you have a stroke, a certain type of stroke, if you have a heart attack, you could be on blood thinners. You will be on blood thinners. There are just 57 billion reasons to be on a blood thinner. Everybody is on a blood thinner. If you're not on a blood thinner, you probably ought to go be on one. All right. Pulmonary embolism, DVTs. A friend of mine is an airline captain, and you know, one of the things about forming a DVT, you know, deep vein thrombosis, right, is sitting all the time, and he winds up with this huge clot in his vein, and now he's on. He has to be anticoagulated to prevent the risk of throwing a PE. So the reason I bring this up is because some of the anticoagulants that you're going to experience during pharmacology relate to thromboxane A2, or they have an effect on ADP. So that's why it's important to understand why you're learning this. Okay? Because I'll guarantee you Nancy Latassi is going to require you to know it. I'll tell you what, getting her over here in Mark Britton, that was a flipping coup right there. I mean, I stole a lot of stuff from OU. I didn't really steal it. If they had treated them better, they would have stayed there. But getting those two over here, whoa. What were we talking about?
One of my, well, this is what you're talking about. One of my friends, the guy that I showed you the picture of the finger,
Yeah.
he's a pharmacist, and I asked him if he knew Professor Latassi, and he was like, yeah, I had her. And I said, yeah, I came to OCU, and he's like, damn, Dr. McNeil must be a big deal.
You know, it's just the oddest thing. You know, I was trying to figure out what we were going to do with pharmacology, and you remember that girl, that woman that started out with Epic, that long, dark-haired woman, the first year. I can't remember her name. She was a pharmacologist. She was a pharmacist down in Norman Regional Hospital. I went and asked her initially. I met with her, and you know, because she was young, and you know, it'd be a part-time gig and stuff like that, and I just about had her signed up. And she backed out at the same, you know, right there, and it's like, crap, what am I going to do now? Next day, I get an email from Mark Britton that, hey, you know, I want to talk to you about coming over to work at OCU. And it's like, are you freaking shitting me? I couldn't believe it. It just still, I mean, when I see her up here, I cannot believe it. I just truly can't. I don't even know what we're talking about. All right, so endothelial cells, man, that's really got to be good stuff. This process continues. You get more and more platelets stacking up on each other. Throughout the process here, what you're going to start winding up with is thrombin is the part of the clotting cascade. It's sort of the end. Everything goes to thrombin. Thrombin is able to convert fibrinogen to fibrin. Fibrin is a sticky substance that binds to the different elements, especially these platelets that are laid down here. You see the bluish stuff between them, that's representing fibrin formation that starts building like a spider web over the platelets. Yes, ma'am.
I'm sorry, I maybe lost you, but can you give me a bigger picture of when the primary hemostasis takes place?
Give me one more slide. Give me one more slide. Two more slides. Two more slides, I'll pull it all together for you. All right. So, once you start getting this clot to form, and you see the fibrin in here, it starts to enmesh cells that are going by it. So you get within the thrombus, RBCs, white blood cells, they all become part of the coagulum that's developing on the inside of the vessel. Now, as soon as, I mentioned earlier, as soon as you get the clot to form, you gotta stop it. You gotta stop its further development, and even you gotta start breaking it down as the vessel here heals itself. One of the elements that helps to stop the clot, or break it down even, is this stuff called TPA. TPA stands for tissue plasminogen activator, and I'll talk about it here in a little bit. It's released by the endothelial cells and has an action on the fibrin, and actually sort of dissolves it. All right. Here we go. This is gets to your point right here. How do platelets recognize the endothelial cell? I mean, the damage to go bind to it in the first place. So this represents the damaged part of the vessel here. Outside of the endothelial cells, there's a protein called von Willebrand factor. I'll talk about it later on, but it's produced by the liver. This protein is ubiquitous throughout the body. Platelets have receptors. The platelet is actually an agonist for this protein and sticks to it, as you see here, through the GP1B receptor. That's glycoprotein 1B receptor. Now, platelets also have on their membrane a receptor called GP2B/3A complex. That is converted, or it becomes active in the presence of ADP that allows it to bind with fibrinogen to other similarly active glycoprotein 2B/3A receptors on other cells. That's how you start getting the platelets to stack up on each other through this mechanism. Okay? I bring this up because one of the drugs, or one of the class of drugs, used to treat or provide anticoagulation is a glycoprotein 2B/3A antagonist. Here's your ADP. If you give a drug that blocks ADP, you can prevent this type of platelet adhesion. There are different types, and I guess you probably need to appreciate different words here. If I'm going to stop the coagulum in your vessels, I can either do it by preventing platelet adhesion, or I can interfere with the clotting cascade to prevent clotting, period. So when you start learning these anticoagulants, which is the global group, there are differences in, do I give you something that modifies adhesion or a true anticoagulant? Okay. All right. Now, get there.
So is there really nowhere else intravascularly where ADP is present? Because otherwise, wouldn't you expect clotting to happen, like, even when it doesn't come across a damaged cell?
I'm not exactly sure of the question.
So you said ADP is what causes the conformational change that allows them to bind. So my question is, does anywhere else intravascularly besides damaged cells have ADP just
Well,
floating
ADP
around?
is an I mean, it's everywhere intracellularly, but in the, ADP is released by the endothelial cells in response to damage. So ordinarily, no. At the site of damage, yes. Okay, that's what is one of the many triggers of producing this platelet plug.
You sort of, yeah.
Okay, all right. You also need to know that von Willebrand factor is an intravascular protein that circulates along with factor VIII. Factor VIII is involved in the clotting cascade we'll talk about here in just a little bit. They circulate as a complex, and with activated platelets, this von Willebrand factor, factor VIII complex can actually recognize on the surface of platelets the receptor that will cause a conformational change in factor 10 and initiate the clotting cascade. Just leave it at that for just a second until we get to hemophilia, okay? All right. Now, fibrinolysis, I mentioned this before, thrombin, and I mentioned TPA, tissue plasminogen activator. This is activated by the presence of thrombin. So thrombin is doing two things. It's causing fibrinogen to fibrin, and at the same time, it's causing the conversion of plasminogen to plasmin. Plasmin degrades fibrin. As fibrin is broken up and enters the circulation, you can actually measure, they're called fibrin split products. You can actually measure them in the circulation. The test that you would order is called a D-dimer. If you have sudden shortness of breath, you have a DVT, you have sudden shortness of breath, I'm going to do two things right off the bat. One is I'm going to send you for a CAT scan, because that's how you would diagnose a PE. The second thing is I'm going to get a D-dimer. If you have the presence of, if you have a large D-dimer value, that is a huge indication that you have a clot somewhere. And it's not diagnosing the clot, it's diagnosing the clot being lysed. So understand that. It's not saying, we're not looking for the clot, we're looking for the breakdown of the clot. So the D-dimer, you have to expect, is not going to go up right here at this moment, but give it a few hours to a day or two, and it should keep going up as more and more of these fibrin split products enter the circulation. All right, the fibrinolytic cascade is here. It's just illustrating the presence of the little degraded fibrin molecules there. All right, components of the clotting cascade. We've got the extrinsic pathway, the intrinsic pathway, and they come together in a common pathway, leading eventually to thrombin, which again, for the 50th time, converts fibrinogen to fibrin. Okay? One of the things that we need to appreciate early on is that factors 2, 7, 9, and 10, and it's easy to remember this because it's like one number less than the parasympathetics and the cranial nerves. Instead of 3, 7, 9, and 10, it's 2, 7, 9, and 10. These enzymes require vitamin K as a cofactor to be able to work. So the vitamin K dependent clotting factors are 2, 7, 9, and 10. Okay? let's talk about the intrinsic the extrinsic pathway first. The extrinsic pathway requires damage to the blood vessels and exposure of the underlying substrate to the platelets. I don't want to get into the specifics of the pathways. Suffice it to say, the extrinsic pathway requires an extracellular trigger, and you measure that cascade by what's called the PT, the prothrombin time. The PT, as it says here, assesses the function of these different types of enzymes based on this pathway here. So if I'm going to measure the competency of the extrinsic pathway, it's through the PT. All right. The intrinsic pathway, let me back up here. Yeah, okay, this is what I meant to say here. Vitamin K and coumadin. Vitamin K and coumadin. Coumadin impacts vitamin K. Think of it as an antagonist, really. That's related to the extrinsic pathway. You've got factor 7 involved in the extrinsic pathway, okay, and 10, but 7 principally. So coumadin is related to PT, which is related to the extrinsic pathway. Most people that are anticoagulated are on coumadin. Anybody here know anybody on coumadin? Yeah, quite a few. So one of the things about coumadin is it will increase the PT. And you have to keep the PT within a certain range. If you give too much coumadin and the PT goes too high, that means you have a risk of bleeding. The antidote for too high of a PT or a coumadin overdose is to give vitamin K. Matter of fact, when babies are born, one of the first things they do to them is give them vitamin K, because that's not something that they have a whole lot of in utero. You get a dose of vitamin K to prevent them bleeding, right? I mean, that makes sense. The intrinsic pathway is a little different. It requires, it says the exposure of factor 12, which is called the Hagelin factor, to something that's going to trigger it, to trigger the conversion. And it's got to be something like a negatively charged substrate. You can do it artificially using glass. So if you want to measure the PTT, you add essentially ground glass to the tube to initiate the intrinsic pathway. You measure this not with a PT, but through a PTT, partial thromboplastin time. The PTT, because of how you did it, measures these, or looks out for the competency of these molecules, which are over here on this side. Okay? Again, when you get to the choke points here, factor 10, fibrinogen, both of them are the same. But it's the early on in the pathway where the PT and the PT differ. PTT is prolonged by the use of heparin. Heparin is an IV or subcutaneous injected substance. It's not a pill. Coumadin takes several days before it will become effective because you have to impact all of the vitamin K related pathways or enzymes. Heparin works instantly. And so if you have a PE and are hospitalized, I'm going to start you on heparin today for your immediate concern. I'm also going to start you on Coumadin, knowing that the Coumadin is not going to change the PT for a few days. So you're going to stay on heparin for a few days, and then I'm going to watch your PT as it starts going up, then I can take you off heparin. And that's how you manage a blood clot. All right, what happens when it all goes bad? Hemorrhage. This is active bleeding from an artery, essentially. And you can do certain things. It'd be hard to apply pressure on your parietal lobe of your brain. It'd be hard to put a tourniquet on it. Tourniquets fell out of favor for years, but now they're coming back into favor as a means of controlling trauma, hemorrhage from trauma due to the extremities. You can suture vessels. The easiest way, if somebody comes in and they've got a scalp lesion and they're bleeding like crazy, they take aspirin to prevent heart attacks. People take aspirin, I'll explain it later, you can tell them. You can tell who they are because their blood will clot. They just bleed like crazy. Well, if you've got a nice bleeder up here in the scalp, there's a thing you can do is take a little clamp, like a hemostat, called a mosquito, it's a little hemostat, sort of. And you dig around, you just clamp the tissues until you wind up getting the vessel. All right, so now you've got the vessel clamped and the bleeding stuff. You do, if this is where you think the vessel is, you do what's called a figure of 8 suture. And you tie that down tight, and that draws the surrounding tissue up and will close off the vessel. So that's why it says suturing of damaged vessels. It's pretty easy to do, and you'll be doing it. Burning a blood vessel with cautery, there's a thing called a BOVIE, B-O-V-I-E, that's electrocautery. It's bzz, 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 bzz. It hurts, but it'll certainly, it burns the end of the capillary close. Another way to do it is by this chemical on these little sticks called silver nitrate. That, when you put it on the skin, it burns the skin. So if you have a bleeder that can't, if you're trying to suture something, get a silver nitrate stick and just touch it to the skin, and it will burn the skin black. You don't need to anesthetize them or anything. It doesn't feel good, but it works.
Another question about the drugs. Xarelto, which now they're saying you don't have to take, you don't have to get blood tests and stuff. How is that different from Coumadin?
Well, there are a whole bunch of different, Coumadin you have to measure the PT frequently until you get them stabilized. Most of these GP2, B3A drugs, low molecular weight, heparin, I mean, there are all sorts of things now where you can just give them and you don't have to worry about them because of the way they're released, because of the way they act. You don't have to monitor. So really, Coumadin and heparin are the only two that you really monitor these days. The rest of them you don't. You don't have to.
Is it because of their therapeutic window? Is it narrow? Because we learned for, like, you have to monitor narrow therapeutic windows. Does that have anything to do with it?
Yes, and the mechanism of action of the drug itself.
Okay.
I mean, why is it that you have to monitor heparin, but you don't have to monitor low molecular weight heparin? You know, it's interesting.
Can you give Coumadin intravascularly? Or is it just like a pill form?
No, it's a pill. I don't know of any intravascular form of Coumadin. You know, and people differ. I mean, some people will be just fine on 5 milligrams a day of Coumadin, and it'll put them in that therapeutic window. Some people, and by the way, the therapeutic window for Coumadin differs if you're trying to prevent a reoccurrence of a pulmonary embolism versus a DVT. You know, there are different windows for different diseases. Some people might require 10 milligrams a day. Some people might require 10 milligrams on Monday, Wednesday, and Saturday, 5 milligrams on the other day. You have to really play with Coumadin to get them in that therapeutic window.
So my mom's on Coumadin. That's what hers is like. Every 3 days she has to change her dosage. It's weird.
Yeah, it's some people can get pretty bizarre. Now, coagulopathies, you're going to get more about this when you get to hematology oncology. I think the guy that's going to come in to talk about a lot of this is Dr. Selby, the guy that talked to you at the White Coat ceremony. He's going to come and preach, I believe. Hemophilia A and B and von Willebrand disease. Hemophilia A is by far the most common type of hemophilia. And what this is a factor VIII deficiency. And you remember that previous slide, factor VIII intravascularly combined with von Willebrand factor. Anyway, it's sex-linked, meaning it's on the X chromosome, which means that most people with hemophilia A are males. However, 30% of hemophiliacs with A, it's spontaneous, so some of those can be females as well. But generally, it is a male disease. Interesting, you know, with the whole, Queen Victoria was the one that introduced this mutation into the bloodline, and she essentially introduced hemophilia A into the monarchies of Spain, Russia, UK. It was kind of an interesting story about that. You know, these are bleeding from smaller vessels. This is not like a big blowout bleed. They don't die from exsanguination, really. They bleed out into certain areas. And one of the areas, the most painful area, would be in the joints. That's where they have the biggest problem with pain. Of course, most hemophiliacs, up until a few years ago, died of AIDS because that wasn't tested. And all of the hemophiliacs were receiving blood products, and quite a few of them died of HIV in the 80s and 90s. Okay. Notice hemophilia A is going to have an increased PTT because of factor VIII, but a normal platelet count and normal PT. The same thing happens with hemophilia B. It's called Christmas disease after a guy named Christmas in the 1950s was diagnosed with this. He was found not to have a factor VIII deficiency. It turns out that his deficiency was in factor IX. These are relatively rare. It says about 20% common as factor VIII deficiency. Again, it's X-linked. Christmas was one of those people that died of AIDS. He contracted AIDS, I think, in the 80s and died because of it. Von Willebrand's disease is autosomal dominant and not sex-linked. So there you go. Again, these are characterized by easy bleeding. You can't stop bleeding like if you get a cut, but not large bleeds like if you rip your aorta open. There are certain acquired diseases that we've talked about really already. Liver disease and vitamin K. Liver disease, obviously, because of the clotting factors, the vitamin K dependent clotting factors are made in the liver. 2, 7, 9, 10 are made in the liver. The deficiency of vitamin K itself, like I described with newborns, would be an issue. Of course, vitamin K deficiencies, nutrition due to excessive ethanol or alcohol consumption, and throw on top of that the destruction of the liver with cirrhosis. It's all related to that. Malabsorption, biliary obstruction, if you can't get flow of the normal secretory products out of the liver, you're not going to have it in the blood. And drug therapy itself, like with Coumadin, for example. One of the things about vitamin K is that in Coumadin is that if you're on Coumadin, you have to watch what you eat, because a lot of things contain vitamin K. Green leafy vegetables, probably the worst offender, like spinach. You really have to, if you're on Coumadin, you really can't, you're advised not to eat that, because it will mess up with your anticoagulation. Liver disease, 270, and there you go. Also, 5 and fibrinogen are produced by the liver as well. Platelet abnormalities, we can screen through here. Thrombocytopenia thrombocytopenia by definition is really a decrease in the number of platelets. I said you have around 400,000 per milliliter. You know, that's a range would be 300 to 400,000 per milliliter. If your platelet number starts to fall, and the reason it can fall can be for a whole host of reasons. Down here at the bottom, it says thrombocytopenia may result from decreased production. If your marrow cavity is filled with cancer, you're going to shut down your ability to produce red blood cells, white blood cells, and platelets. If you're myelosuppressed, which can happen with, if you're getting ready to undergo a bone marrow transplant, or there are certain drugs, well, actually any drug, one of the side effects is myelosuppression. You shut down your ability to produce blood cells. Okay? That's a side effect of any drug that you take. You look on the warning list, and they'll always list this. One of the things is thrombocytopenia, drug-induced thrombocytopenia. That has to do with decreased production. Now, you can also have increased utilization if you have somebody with massive trauma from an MVC or something. They're going to be using up a lot of their platelets. Increased destruction, an example would be if you had a mechanical valve. You underwent valve replacement, and they put a mechanical valve in, and this piece of metal is flopping back and forth. That metal tends to tear up RBCs, tear up all the cellular elements in blood. You can see the petechiae right here. You see the little spots like that? That's petechiae. Petechiae you get with a lot of viral infections. It's pretty common. Functional disorders, there can be, you can do things to platelets to keep them from functioning appropriately. One of them is you take aspirin a day. How many people in here, their parents take an aspirin a day? You probably don't know it, but I guarantee most of your parents or grandparents take an aspirin a day to prevent heart attacks. If that's all you do, take an aspirin, if you're having a heart attack, and you take an aspirin, actually 2 to 3 aspirins, then you will save 50% of the people having a heart attack. If you don't do anything else, you give them 2 or 3 baby aspirins, that's all you need to do. You save 50% of them. The way aspirin works is it blocks thromboxane A2. The deal is it blocks that receptor on all platelets. If you take 1 baby aspirin, it will block that receptor on all your platelets. So your bleeding time will increase. Bleeding time means they poke a hole in your skin and they measure the length of time it takes for you to stop bleeding. Called bleeding time. So if you take 1 aspirin, your bleeding time will increase. In order to get it back to normal, you have to replace 30% of your platelets. You replace platelets at the rate of 10% a day. So that means that if you take 1 aspirin, your bleeding time will increase, will stay increased for 3 days. You follow me? You want to say it again? All right. So if you take 1 aspirin, it affects all your platelets. In order to get your bleeding time back to normal, you got to have a pool of 30% of unaffected platelets. You replace platelets at the rate of 10% a day. So in order to get 30%, it's going to take you 3 days. So 1 aspirin will last you 3 days. So why do they tell people to take an aspirin a day?
Build it up.
Huh?
Because you can't remember
Build
taking
it
it.
up.
Yeah,
Yeah,
who
it's just
can
easier.
remember the 3rd day? That's why, you take an aspirin every day because who can remember every 3 days? You ask my wife, she couldn't remember to take her birth control every day, that's why we have Emily. So, go take a break.